Now moving on to our fourth section, and we'll be discussing thoracic outlet syndrome in this. We are briefly going what is a Glad-Summer type of neurogenic thoracic outlet syndrome and what is Glad-Summer type hand. We'll briefly know how to diagnose thoracic outlet syndrome, especially when we are dealing, because there's multiple causes which are causing the thoracic outlet syndrome, and then how to do the surgical decompression, because it mainly affects the lower plexus, that is C8T1 mainly. Therefore, what are the surgical mechanism by which we can relieve the nerve compression, especially of the ulnar nerve and associated with the thoracic outlet syndrome. Thoracic outlet syndrome, it could be due to multiple other causes. One of the most common causes is actually the subclavian vessel syndrome. That is usually when they pass just below the clavicle, there is abnormality of these subclavian vessels by which they can compress the lower nerve roots of the brachial plexus, that is the C8 and T1. Other causes could be lower trunk of the brachial plexus mainly, that is, and subclavian vessels. Usually we know that the brachial plexus starts from C5 to TA1, that is C5, C6, C7, C8 and T1. But it actually enters into the axilla between the scalene anterior and scalene medius muscle. So if there is any nerve which is actually compressing these two muscles, or for example this hypertrophy of scalene muscles, or there could be congenital aberrant muscles which could be present between the scalene anterior and medius, then this can also compress the brachial plexus over there, leading to thoracic outlet syndrome. So there could be anomalous scalene muscle, I just told you, between the scalene anterior scalene muscle medius. Therefore, it can lead to thoracic outlet syndrome. Or there could be, usually it's mainly C8, the T1, which is actually compressed, and therefore it's mainly showing the ulnar nerve neuropathy. That is, there is sensory changes in the ulnar 1.5 fingers, that is the little finger, and ulnar side of the ring finger, mainly in the hypothenar region of the hand, wrist joint, and as well as the forearm, medial side of the forearm, and medial side of the arm may be a numb, or there may be sensory changes over there because C8T1 is mainly involved. Coming to what is Glad-Summer type neurogenic thoracic outlet syndrome. This is actually associated with wasting of hypothenar eminence and forearm musculature. Mainly the C8T1 is actually compromised, and this result is also called the formation of Glad-Summer type neurogenic hand. That is due to this wasting of hypothenar. There is actually clawing is also less common, although there is maybe some degree of clawing as well. But usually the ulnar neuropathy is associated with thoracic outlet syndrome. There could be lumen contraction, or there could be emboli formation, cyanosis and thrombosis, edema of the mainly the little and the ring finger. All the symptoms are of the ulnar nerve compression syndrome, but the problem is not in the ulnar nerve, but the problem is higher up in the neck, that is resulting due to thoracic outlet syndrome. Usually it's due to subclavian artery, which gets actually really compressed. Clinical features include pain and paresthesia. I just told you, mean the C8T1 dermatome is involved, that is medial side of the arm, medial side of the forearm, hypothenar side of the palm, and the ulnar 1.5 fingers. There is mild clawing, as with the ulnar paradox, that the higher the lesion is, there will be less clawing. The lower the lesion is, in the case of ulnar nerve, there will be increased clawing. There is a wasting and weakness of intrinsic muscle because the ulnar nerve is mainly paralyzed. There is long neck with sloping shoulder, usually due to problem is with this scalene muscle as well. So this may be associated with these sorts of problems as well. There is cyanosis and coolness of the finger because the autonomic nervous system of C8T1 are also affected. There is increased sweating and unilateral Raynaud's phenomena, especially associated with the Raynaud's of the that is contraction, especially due to cubital and blueness and numbness of the fingers of the ulnar side. There are 3 tests which are actually done to rule out whether it is associated with thoracic outlet syndrome or not. There is Edson test, there is Rice test, and there is Roos test. In Edson test, the patient is sitting right up like this with arms slightly abducted, and the examiner's hand is on the radial pulse. And if suppose it's a thoracic outlet syndrome of the right side, the patient would be asked to tilt his or her neck towards the right side, asked to inhale and hold his or her breath for a few seconds with his neck on the right side. With this, as the pressure on the brachial plexus increases, there is actually decrease in the pulsation of the radial nerve. Why? Because subclavian artery is actually getting compressed over here. In the right test, it's actually opposite of the Edson test. The patient is asked to tilt his or her neck opposite to the side of the lesion. And once that is, if it's the lesion is on the right side and we're suspecting thoracic outlet syndrome of the right side, patient would be sitting up like this and asked to tilt his or her neck towards the left side, that is the opposite side, and then the examiner will try to raise, abduct the arm, and this would abduction and moving away from the neck would result in subclavian compression and decreased pulsation of the radial artery. Now coming to the Roos test, it's actually different because in the Edson test and the right test, arm was by the side, the wrist was forearm was supinated and elbow was extended. The patient was sitting like this. But in case of the Roos test, there is different. It's slightly abducted, elbow is flexed, and patient is asked to clench his or her fist multiple times for 3 minutes. As this is a provocative test as well, now this kind of a maneuver with arms abducted, elbows flexed, and forearm pronated, and with the movement of the finger, this would actually provoke the ulnar nerve, especially the C8T1, and if this is associated with compression, this would result in reproduction of the symptoms, especially paresthesias on the ulnar side, over the medial aspect of the forearm and to the medial aspect of the arm as well. So this is called as positive Roos test. Now coming to the diagnosis, how to diagnose, depending upon what is the cause, we have to do multiple tests to diagnose thoracic outlet syndrome. It could be X-rays of the neck. Why? Because cervical rib is also a cause of the thoracic outlet syndrome. So X-rays of neck would show a cervical rib and an extra rib which could be compressing the subclavian vessels, or it would require an MRI scanning of the cervical spine, because there may be compression may be higher up involving the C8T1 lesion. There may require a brachial plexus MRI scan so that we know what kind of nerve injury, and usually it's always the lower root which is involved. Electrodiagnostic tests which include electromyography and NCS may needs to be performed so that we may know that where actually the compression is, and usually it's always higher up in the axilla wherein the subclavian vessel is impinging on the lower nerve roots, that is the C8T1 level. Cervical ribs, it could be incidental finding as well leading to thoracic outlet syndrome. They usually a normal radial test, but in case of provocative test, Edson a right test is performed, this can lead to subclavian vessel impinging on the brachial plexus leading to decreased radial artery pulsations. I told you the Roos test, which is a provocative test in which the arm is abducted and actually 90 degrees, forearm is flexed to 90 degrees, and with elbows flexed to 90 degrees, forearm is pronated, and the patient asked to clench his or her fist multiple times for 3 minutes. This is what is a provocative test, and it would actually result in symptoms which are associated with ulnar nerve neuropathy, that is tingling, numbness, sensation of the ulnar 1.5 fingers, numbness and tingling over the medial side of the forearm, and numbness tingling on the medial side of the arm as well. There may be mistaken, could be a double crush syndrome as well. We may be thinking it's a cubital syndrome, and even once the cubital tunnel is released, the patient can still have a problem due to thoracic outlet syndrome. There is wasting of T1 and weakness of C8, especially which is the coarse intrinsic muscles of the hand, and lumbricals are supplied with ulnar nerve, so they get usually the interossei are atrophied. They may be associated with cervical spondylosis as well, or it could be with the Pancoast syndrome, or it is due to the tumor of the lung, in the apex of the lung may be compressing the lower end of the brachial plexus leading to Pancoast syndrome. Or there may be associated rotator cuff lesion as well, that there was some kind of injury, a traumatic injury which has resulted in the loss of C8T1, and which may be associated with thoracic outlet syndromes. Coming to the treatment. Treatment could be initially conservative, which could be exercises which actually decrease the compression and stretch on the nerves. It could be postural training. The patients may be advised not to remain in certain posture which actually increase the pressure on these nerves. Then could be analgesics because they may be associated with severe neuropathy and pain and numbness as well. Other could be operative treatment. If it is cervical rape, that can be excised. If it's via suprascapular transaxillary approach, or if it is a vascular problem with the subclavian vessel, then there could be vascular reconstruction which can be done as well. Depending upon what is the cause of the, if it's Pancoast tumor, then we can go for excision of the tumor of the lungs. But depending upon what is the cause of thoracic outlet syndrome, usually the operative treatment is directed against the impending cause. Now coming to the other rare form of disorders called as lower limb compression syndromes. There are some nerves which can get compressed in certain areas in the lower limb as well. And classically is the example of compression of lateral cutaneous nerve of thigh, which once crosses the inguinal ligament just lateral to the anterior superior iliac spine, it can get compressed over there, leading to numbness, tingling and burning of discomfort of the lateral aspect of the thigh, called as meralgia paresthetica. And there is maybe increased sensibility to pinprick. But usually, if the problem is on the lateral aspect of thigh, it is a cutaneous nerve, so mainly it has no muscle being supplied, but only the sensory changes are observed. Then could be tarsal tunnel syndrome. This is due to the lateral pronator nerve, which can get entrapped over there in the tarsal tunnel, leading to pain and sensory disturbances, paresthesia and numbness. Then it could be, as it is mainly supplying the muscles, it could lead to posterior tibial tendon insufficiency and loss of the medial arch. Therefore, the treatment could be medial arch support, and we may have to surgically decompress this nerve so that the nerve supply and muscles do not completely atrophy. The other options could be digital nerve compression in the foot. Usually with hyperextension or with hyperflexion, these nerves, plantar nerves, can get compressed at the level of the head of the metatarsals. This can lead to neuropathy of the digital nerves, especially called as Morton's metatarsalgia. In this section, we have briefly gone through the thoracic outlet syndromes. That is a very important cause of double crush syndrome. It could be due to cervical rape, it could be problem with the subclavian vessels, it could be Pancoast tumor, it could be multiple other causes which could be compressing the lower half of the brachial plexus, that is the C8 and T1. There are different tests which can be used clinically to diagnose, that's Edson, Rice and Roos test. But we may also, along with the history and examination, we may have to go with certain tests such as the brachial plexus, MRI, cervical spine MRI, and NCS and EMGs of the brachial plexus to exactly diagnose whether it is thoracic outlet syndrome or not and what is causing it. Keep watching sqadia.com. Thank you very much.